Okay, so no, I didn't shorten my title, Yuli. It just got cut off a little bit. But I'm going to be talking about HIV-related malignancies. I'm going to focus on epidemiology, pathogenesis, prevention, and mortality. This is what the next 45 minutes will look like. After background and introduction, we'll spend a little bit of time on the effect of antiretroviral therapy on cancer and AIDS. We'll talk about the pathogenesis behind that. This is a very literature-heavy topic, so we'll spend some time on the literature as well. I'll talk about important epidemiologic aspects of the AIDS-defining malignancies and the non-AIDS-defining malignancies, prevention, and conclusions. So this is the simplest slide I have. It kind of goes downhill from here. But HIV-related malignancies are classified basically as AIDS-defining and non-AIDS-defining. The AIDS-defining malignancies we all know: Kaposisarcoma, non-Hodgkins lymphoma, and invasive cancer of the cervix. There are a lot of non-AIDS defining malignancies, but the most common and the most documented in the literature are the ones that I will talk about, and that's anal cancer, Hodgkin's lymphoma, hepatocellular carcinoma, skin cancer, and lung cancer. So in the early 1980s, many gay men around the world started to develop this rare malignancy called Kaposisarcoma, and this is basically how the AIDS epidemic began. When the CDC started making its initial case definitions for AIDS, Kaposisarcoma and primary CNS lymphoma were the first to be on the list as AIDS-defining malignancies, and that was in 1982. Then in 1985, they added non-Hodgkin's lymphoma, and in 1993, they added invasive cancer of the cervix. Pre-heart, really only 10% of deaths were due to malignancy, and this is a lot different now. Now it's we've gone up to about 1 out of every 3 patients with HIV will die of malignancy. So I thought I would throw this in because I do mention these quite a bit in the presentation. A lot of authors draw their data from these large databases around the country reporting AIDS in these cancer registries. They're able to pull their data from these registries and make links and conclusions from them. The U.S. HIV/AIDS Cancer Match Registry Study Group, they also look at the AIDS population at diagnosis, their characteristics, and they link they extrapolate a linkage to cancer looking at local cancer registry data. So I mentioned that a few times as well. And then a Swiss HIV cohort study produced a large number of publications, though, so we learned a lot from this study. One of the most successful epidemiological studies in Switzerland. It's a prospective multi-center cohort study of HIV-infected adolescents and adults based in 7 outpatient clinics and labs. They basically followed these patients and they looked at the characteristics, disease characteristics, the effect of antiretroviral therapy in preventing AIDS and death. This was started in '88, but they actually used records dating back to 1982. And as of 2003, they had about 12,500 patients enrolled in the study. So general observations we've been able to make from all of these studies. Well, number one, we know that HIV-infected individuals have a well-documented increased risk to develop malignancy. More importantly now is that the spectrum of cancer is changing, and that's thought to be because of the use of antiretroviral therapy. When I talk about the HAART era, that actually started in 1996 with the availability of protease inhibitors. So overall generalizations that we can make are that there's a dramatic reduction in AIDS-defining malignancy, and there's an overall increase in the non-AIDS defining HIV-related malignancies. So we'll talk about those. We also know now that malignancy is becoming an increasingly important cause of death in this population, and most of these tumors are associated with oncogenic viruses. So since the start of the HAART era, we obviously were able to have immune reconstitution, which led to prolonged survival with chronic immunosuppression, however. So due to HAART, we did have a dramatic reduction in morbidity and mortality with reduction of AIDS-defining malignancies as well as reduction of opportunistic infections. The epidemiology and clinical profile of these cancers have changed. We'll talk about that in detail. The incidence of KS and NHL has declined, but the one exception is that invasive cancer of the cervix has not shown a further increase in the heart error. So that's the one exception. Hodgkin's lymphoma and the other non-AIDS defining malignancies do tend to increase, and they think that this is because of lifestyle factors. One important thing to know is that the common cancers that occur in the general population, including breast, colon, and prostate, are actually not considered HIV-related malignancies because these are not increased in the HIV population. The incidences are the same. We've also had improved responsiveness of the malignancy to therapy in the heart error. So looking at some of the literature here, data pulled from U.S. AIDS and cancer registries, looking at 325,000 AIDS-infected patients in the pre-heart era, which is 1990 through 95, and the post-heart era, 1996 on. They found that the incidence of KS declined, and you can see that they saw that 1839 cases decreased to 335 cases per 100,000 patient years. The incidence of NHL, the same, went from 1066 to 390 cases per 1,000 patient years, so pretty significant. The Swiss HIV cohort study, looking at about little over 7,000 patients, confirmed this decrease. And also a post-heart study done in 2005 in France, looking at 64,000 HIV-infected patients, they saw that about 1/3 of deaths were due to malignancy in this population. 42% of those were AIDS-defining, and 58% of those were non-AIDS defining. And another large study done in Europe and North America, looking at heart and cancer patients from 1996 to 2006, post-heart era. This was actually recently seen in the CID 2010. They looked at over 39,000 patients. Of these patients, 1876 deaths occurred, and 85% of these deaths did have a definitive cause, or 1597 patients. So about 25% of these were AIDS, were malignancies. 14.8% were AIDS-defining malignancies, and 11.8% were non-AIDS-defining malignancies. And then you can see the further breakdown: large percentage due to AIDS-related infections, non-AIDS-related infections, non-specific AIDS complications, violence, liver disease, cardiovascular disease. So the 2006 Oncogenic, if I pronounce that right, French study, basically, they looked at HIV-positive patients diagnosed with new malignancy in France in 2006. They looked at patient characteristics, distributions of malignancies, as well as one-year survival. They looked at a total of 694 new malignancies that were reported. Detailed data were available for 669 patients, or 673 malignancies. Now this will be a little bit hard to see in the back, but if you look at the percentages, about 1/3 of all of the malignancies were AIDS defining, and 2/3 were non-AIDS defining. Of the 1/3 AIDS defining, you can see that over here is the men, over here is the women, and of the 1/3 AIDS defining, lymphoma, which is the blue, was the most common, and coming in second place was Kaposisarcoma. And in women, again, lymphomas, then Kaposisarcoma, and then invasive cancer of the cervix. I couldn't separate these, but the important thing here is that in the top graph, they're looking at the characteristics of the AIDS-defining malignancy patients. And the mean AIDS CD4 count was 200 and less. And a very small amount of these patients were controlled on antiretroviral therapy with a CD4 count, or with a viral load less than 500. The bottom graph is looking at malignancy, and you can see NHL had the worst survival. Above that was cervical cancer, and above that was Kaposisarcoma. So this is looking at the non-AIDS defining malignancy patient characteristics. And these patients, you can see that the mean CD4 count was actually well above 200. And more than half of these patients were controlled on antiretroviral therapy with a viral load less than 500. And the mortality here, lung cancer had the worst prognosis, followed by hepatocellular carcinoma. Hodgkins disease and anal cancer actually had the highest survival. Looking at the causes of death, double were due to non-AIDS defining malignancy, and you can see that quite a few were due to AIDS defining malignancy as well, just much less. And then you've got other AIDS complications, medication complications. So going into pathogenesis, there are several factors that contribute to this increased incidence of malignancy seen in this population. Number one is obviously immunosuppression. If you can't clear the oncogenic viruses, you can't clear their antigens, then you're more likely to develop cancer from them. Immune dysregulation has also been implicated. There is evidence from one study that increased levels of pro-inflammatory cytokines like IL-6 might contribute to the development of certain tumors, especially B-cell lymphomas and Kaposisarcoma. So that's been found to be significant. And also, although HIV is not itself considered to be oncogenic, HIV proteins have played a role in pathogenesis. And these are just study findings which kind of prove this. Components of the HIV viral genome have been incorporated into the FIR gene complex on chromosome 15 in some HIV-associated non-B-cell malignant lymphomas. Also, the HIV TAT protein has been shown to be a growth factor for KS, and just simply knowing that effective antiretroviral therapy does lower the incidence of these malignancies. Oncogenic viruses, very important. These viral latent genes are expressed in tumor cells and seem to have a direct role in tumor pathogenesis. The most known are EBV, HPV, HHV8, HBV, and HCV. EBV is associated with lymphomas to variable degrees. About 50% of systemic NHLs are associated with EBV, and nearly 100% of CNS lymphomas and Hodgkins lymphoma are all related to EBV. HPV is not only seen in invasive cancer of the cervix, but you have to think of anal cancer, vulva, penis, perianal skin involvement. HHV8 not only seen in KS, you can also see it with primary effusion lymphoma as well as multicentric Castleman's disease. Hepatitis B and C are associated with liver cancer. I just wanted to show you this just so that you could see the variable degrees that EBV is associated with these lymphomas. They show you that 100% you can see with primary CNS as well as with Hodgkin's lymphoma. But then you have these variable degrees here that it's associated with Burkitt's, diffuse large B-cell, plasmablastic. KS HV is HHV8, it's Kaposisarcoma herpes virus. You can see that with Kaposi's as well as the Castleman's disease, as well as to some extent, or to all extent, primary fusion lymphoma. And then on the bottom they have the HCV and HBV associated with primary hepatocellular carcinoma. So now we go into the AIDS-defining malignancies, which we know is NHL, KS, and invasive cancer of the cervix. The risk factors here and the outcome predictors are pretty simple. It's immunosuppression and HIV viral replication. And especially with primary brain NHL, you usually see this with profound immunosuppression, CD4 count less than 50. Worldwide, NHL is known to be the most common AIDS-defining malignancy and is still a very frequent cause of mortality even in patients who are controlled on antiretrovirals. There are many classic forms of lymphoma. You've got Burkitt's, diffuse large B-cell, primary fusion or body cavity based, plasmablastic lymphoma of the oral cavity, and Castleman's disease. 70 to 90% of all AIDS-related NHLs are going to be intermediate or high grade, and almost all are due to large B-cell and Burkitt's lymphoma. Studies have also found a significant relationship between the subtype of lymphoma and HIV disease. Systemic diffuse large B cell is more common with CD4 counts of less than 200. Burkitt's actually is known to happen with less immunodeficient states. And primary CNS lymphoma, again, is usually seen with CD4 counts less than 50. Atypical features seen with NHL in this population: propensity for advanced disease, presence of B symptoms at presentation. They have a propensity for extranodal disease, including bone marrow involvement, leptomeningeal disease, and disease in unusual locations, such as body cavities, jaw, rectum, and soft tissues. Prominent and also a prominent association with EBV and HHV-8. In developed countries, introduction to HAART we know led to reduction of NHL incidence, although less marked than KS. These are a few large studies that looked at this. Again, the Swiss HIV cohort study, looking at HAART and NHL incidence. You can see that in the pre-HAART era, they found 13.6 to 1,000 13.6 cases per 1,000 patient years. In the post-HAART era, that number dropped to 1.8 cases per 1,000 patient years. They also found that in non-HAART users, the CD4 count was inversely associated with NHL incidence, and in the HAART users, really only age was significantly associated. Within the French hospital database of HIV, you can also see a similar trend. They go from 8.6 to 4.3 to 2.8 in recent years. This has been confirmed in European and other United States studies as well. Also, one thing to know is that multiple studies did show that there was a more pronounced decline in primary CNS lymphoma relative to other lymphomas. So in the pre-HAART era, prognostic factors included age greater than 35, stage 3 or 4, CD4 count less than 100, and history of drugs. And in this one study, 0 to 1 factor was associated with 46-week survival, 3 to 4 factors associated with 18-week survival. And the major prognostic factor was control of HIV viremia with HAART therapy. They found that, or they were able to conclude that virologic response within 2 years of diagnosis of non-Hodgkin's lymphoma is associated with improved overall survival. Moving on to Kaposisarcoma, which is a low-grade soft tissue sarcoma of vascular origin associated with HHV-8. Although the incidence has dramatically declined with HAART use, KS is still very prominent and second most common tumor worldwide. In 1998 study, 800 men, 400 of which were HIV positive. Of those that were co-infected with HHV-8, the 10-year probability of developing KS was 50%. And in the recently published study, Euracida, you can also see a downward trend going to 1.7 in 1,000 patient year cases in recent years. So the trend has significantly declined. In the US and Europe, HIV-related KS is predominantly seen in men who have sex with men. In early HIV studies, KS was noted in 20 to 30% of the MSM population. The two main populations at risk, we know MSM as well as patients that are from sub-Saharan Africa. And strong outcome predictors, again, we're dealing with immunosuppression and viral replication. The risk of visceral KS has decreased more than the risk of cutaneous, so we'll see cutaneous more now. Patients with KS on HAART exhibit a less aggressive presentation. And I found this interesting. The risk of developing disease is thought to increase with HHV-8 antibody titers. However, many studies have looked at this, and quantification of HHV-8 viremia has not been shown to be of value in diagnosis or clinical monitoring. So moving on to invasive cancer of the cervix, second most common cancer worldwide in women, more frequent in low-income countries. Women infected with HIV thought to be through lifestyle risk factors are also co-infected with HPV, or commonly co-infected with HPV. This leads to a significant increase in these pre-invasive lesions called CIN, cervical intraepithelial neoplasia, and higher risk for invasive cancers. HIV-positive women with CIN typically have advanced disease diagnosis and a high recurrence rate, which is why cervical cancer screening is very important and a standard of care. HIV-positive women with cervical cancer are more likely to die as a result of cancer than HIV-negative population. And in one early series, women with ICC had therapy that failed and almost all died with a mean survival of 10 months. The use of HAART, again, has had no effect in outcome or incidence. So although ICC is elevated in the AIDS population, there's no increase with the use of HAART or decrease with the use of HAART associated with HPV, and more specifically HPV type 16, 18, 31, and 45. HPV 16 and 18 are the targets of our current vaccines, and these cause about 70% of all the cervical cancers worldwide. HPV type 6 and 11 are more for genital warts. The link between HPV and HIV are thought to be due to lifestyle risks as well as host immune responses to these viruses. And the significant relationship between the risk of HPV is thought to be also be due to the degree of immunosuppression. And this was looked at in one study of 309,000 American patients with HIV or AIDS. They found that the lower the CD4 count, the higher the risk of developing cervical cancer. So moving on to the non-AIDS malignancies, the risk factors are multifactorial, not just immunosuppression, but aging, many different lifestyle habits, and co-infection with oncogenic viruses. Other factors contributing to this increased incidence is the fact that screening is better and we're finding these cancers more, increased prevalence, more frequent detection of incidental lesions, and better reporting. Important observations in the literature that we've been able to make is that number one, more common epithelial cancers found in the general population, I mentioned this earlier, breast, prostate, and colon, are actually not increased in the HIV population. These cancers often present in younger ages with atypical pathology, including higher tumor grade, more aggressive clinical behavior, and presentation with metastatic disease. And these features lead to poor outcome, rapid progression, high rate of relapse, and poor response to treatment. So there's a whole lot of these. The more common: skin, anal cancer, Hodgkins lymphoma, liver cancer, lung cancer. But you've got this whole other column that you can see that are increased in the HIV population, and you see no increased incidence with breast, prostate, and colon. Starting with Hodgkins lymphoma, among the most common non-AIDS defining malignancies, incidence is clearly increased with HIV-infected patients. Multiple large series and reviews, they actually found that there was a 5 to 25-fold increased risk compared to the general population. And also two papers that I read, they actually documented this complex relation between CD4 and Hodgkins, where Hodgkins lymphoma incidence peaks in those that have a CD4 count of 150 to 250, but then this incidence lowers when the CD4 counts goes higher or lower than that. So atypical features, more aggressive. You're going to have unfavorable histologic subtypes here. About 1/2 to 2/3 of cases are due to mixed cellularity and lymphocyte depletion. Nearly all patients are associated with EBV. Bone marrow involvement is found at presentation in 50% of patients. B symptoms at presentation, and these patients are presenting with more aggressive disease, wide dissemination, and actually extranodal disease may be seen in 75 to 90% of these patients, including liver, spleen, and brain. Prior to HAART, patients with Hodgkin's lymphoma in the HIV setting had a limited median survival of about 1 to 2 years. However, similar to non-Hodgkin's lymphoma, in those who respond to HAART therapy within 2 years, survival has improved. Moving on to skin cancer, which is creeping up as a more common cause of non-AIDS defining cancer. Basal cell cancer and squamous cell cancer are the most common, basal cell being more common. Atypical characteristics, again, just very aggressive, tend to occur in younger patients. Look out for tumors that are not in sun-exposed areas, increased rate of recurrence, overall poor outcome. And don't forget that these patients are also prone to have HPV-associated genital lesions. And their risk factors are similar to the traditional skin cancer risk factors: fair skin, sun exposure, family history. So in one study where they looked at 4,500 HIV positive patients over a 20-year period, 6% of those patients developed skin cancer, most commonly basal cell, and also they found that there was a threefold increased incidence of melanoma as well. And the melanoma is obviously more aggressive as well, poor prognosis. Anal cancer, very similar to cervical cancer, strongly associated with oncogenic subtypes of HPV. Incidence is dramatically increased in the HIV population. And like cervical cancer, again, there's no clear difference in incidence between the heart and the non-heart users. Biologic consequences of anal dysplasia, or AIN, are considered analogous to cervical dysplasia. There is marked increase in the incidence of both anal intraepithelial neoplasia and invasive cancer. And in one study, the anal cancer incidence rate was about 120-fold higher, actually, 60 cases per 100,000 patient years in the HIV population compared to 0.5 cases in the general population. So in one study looking at AIDS patients in the U.S., the risk of anal cancer did not change significantly between the pre and post-heart era. And in the French hospital database, they also looked at this, and this actually kind of had contrasting results where you actually do see a bit of a trend up, increasing trend in the post-heart era. And also one recent study looking at survival, they saw that the survival for HIV positive and HIV negative population, the survival was similar, with 2-year survival rates of 77% and 75% respectively. As with cancer, the cervix as well, screening has been shown to provide substantial benefits, and we talk about this a little bit more later. But in one study, they looked at screening homosexual and bisexual HIV positive patients with these anal pap smears, and this did provide benefit with costs comparable to that of other screening prevention programs, but in other populations it did not show to be cost effective, like women or non-MSM men. So pap smears, anoscopy, anal biopsy, this is what is necessary to diagnose these lesions and cancers. And also just don't forget that any person that's diagnosed with anal cancer, especially if male and younger than 70, should be evaluated for HIV. Liver cancer, studies have showed that it's about 7-fold increased in the HIV population, most common risk factors being co-infection with hepatitis B and C, chronic alcohol intake, and aflatoxins in the diet in Africa. The influence of HIV and immune status, however, is unclear, and the HIV Swiss cohort study looked at this and saw that there was a higher rate with a standard incidence ratio of 7, and it was mostly explained again by co-infection with HBV and HCV, or HCV and IVDA. And then this French Germavik study group also looked at this and saw an increase in death due to liver cancer in the post-heart era. Atypical features, they're presenting with symptomatic disease, higher alpha-fetoprotein levels, infiltrative lesions, aggressive tumor behavior, extrahepatic metastasis, and poor prognosis with advanced disease. And experience with HIV and liver cancer is limited. Lung cancer, I think this is the last one. HIV-infected persons have elevated risk of lung cancer as well, 2 to 7-fold higher in the majority of studies. In 2007, the HIV-AIDS cancer match study did look at this and confirmed that there was an association, especially in those that are young, between 15 and 29 years of age. And this was thought to be because this particular group of people have an increased prevalence for smoking. Atypical features for the lung cancer, younger age, advanced stage of disease at diagnosis, and adenocarcinoma was actually more common in this group. Moving on to prevention. Despite the increased incidence of non-AIDS defining cancers, it is still unclear as to what the optimal surveillance should be here, but we do know that controlling HIV viremia is very effective. It decreases the risk of AIDS-defining malignancies, opportunistic infections, and improves the prognosis in those patients that are diagnosed with HIV-related malignancy. Control of risk factors, very important, and efforts should be made to avoid infection with oncogenic viruses. In terms of screening, very important topic. Unfortunately, HHV-8 and EBV screening has not been found to be helpful in the prevention of the associated cancers. However, cervical and anal cancer prevention screening is very essential for women, homosexual, and bisexual men. In terms of cervical cancer screening, we can do a whole hour or two lecture on this alone. But basically, it's very important in the detection and treatment of CIN 2-3 and prevention of cervical cancer. Screening with cervical cytology or pap smears and HPV testing has reduced the incidence and mortality of cervical cancer more than 70% in the general population. And it's just important to be aware that this will still be important even post-HPV vaccine era, since the vaccine will not prevent 25 to 30% of cervical cancers, and it won't protect women that were already infected with certain HPV types prior to vaccination. In terms of anal cancer screening, and I'm sure Dr. Samboon would have a lot to say about this, there are no formal guidelines right now, but we do have suggestions, and I mean, just kind of looking at the literature and up to date, who should be screened. All men who have sex with men, regardless of HIV status, evidence suggests that they should be screened. Women with cervical cancer, high-grade vulvar SIL or vulvar cancer, should be screened. All HIV-positive men and women, apparently, regardless of sexual orientation, and transplant recipients. The data on women and non-MSM men, whether or not they're HIV infected, the data is very limited, but the data does suggest that anal cytology screening would be helpful here. And all I'll say about the HPV vaccine is that the efficacy and safety of this vaccine has not yet been established in the HIV infected risk group. So in conclusion, in the pre-heart era, less than 10% of deaths were due to malignancy, but in the post-heart era, this number has increased to about 1/3 of patients in most studies. Dramatic decline in AIDS-related malignancies with the exception of cervical cancer. Overall increase in the non-AIDS defining malignancies, which represent a new challenge in the care of patients with HIV infection, and improved survival in patients who are diagnosed with malignancy. Common factors contributing to malignancy include immunosuppression, immune dysregulation, HIV viral proteins, co-infection with oncogenic viruses. These viruses are just more aggressive and present at a younger age. And screening, control of risk factors, avoidance of co-infection with these oncogenic viruses, and control of viremia and immune reconstitution with heart will provide a substantial benefit. And here are my references and any comments, questions. Thank you very much.